Hey everybody, and welcome back to another video here at Whiteboard Doctor. We appreciate you checking it out. Today, interesting topic that is probably pertinent to a lot of people, both medical professionals, medical trainees, as well as the general public who has an interest. And we're going to be talking about non-invasive positive pressure ventilation strategies. Specifically, three different types of non-invasive positive pressure ventilation strategies, and those are CPAP, or continuous positive airway pressure, BPAP, also known as BiPAP, which is bilevel positive airway pressure, and then a newer one called AVAPS, or average volume assured pressure support. So lots of abbreviations and nomenclature here, which we will obviously dive into. Before we get going though, just quick shout out to the page. If you have not been to the Whiteboard Doctor page before, this is it. We'd love for you to subscribe, follow along. If you have interest, check out some of our other videos and playlists. We have a great critical care playlist here, pulmonology playlist here, full of different videos. We're gonna do a quick 30-second break for our introduction. Don't go anywhere though, we will dive right in. Hello everyone, and welcome to another video here at Whiteboard Doctor. Thanks for joining us today. Here at Whiteboard Doctor, our mission is to provide you with free, interesting, relevant, understandable medical education and news for all types of lifelong learners, trainees, and practitioners. We have weekly videos that we debut Fridays at 5 p.m. Eastern Time with bonus medical education videos posted throughout the week. We'd love for you to join the Whiteboard Doctor community and follow along by hitting the subscribe button located in the bottom right-hand corner. We also encourage all likes and comments, even if it is just to say hello. All our video descriptions contain links for additional related videos that might be interesting, so don't forget to check those out. And lastly, a quick disclaimer, none of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on. With no further ado, stay well, keep learning, and let's get to the video. All right, thanks for sticking around. So CPAP, BiPAP, and AVAPS, what are they? When do you use them? How do they work? At home or in the hospital? When can't you use them? Different types of masks, all things we're going to talk about today. To start though, we wanted to go through kind of an introductory thing. So these are what we call non-invasive positive pressure ventilation strategies. And non-invasive positive pressure ventilation, also abbreviated NIPPV, non-invasive positive pressure ventilation. Some people abbreviate them NIV. And the non-invasive component, right, the non here, is to make it essentially the opposite or different than invasive positive pressure ventilation, and that usually is intubation and ventilation. So these different modalities are strategies used to help patients breathe that do not require an endotracheal tube being placed into the airway and hooking them up to a ventilator. Instead, it involves a mask that goes over the face. So this is a picture from the Centers for Disease Control, but we wanted to pull up a couple other pictures just so you can kind of get a visual of what this looks like. So this is literally just Googled CPAP on the internet here, and you can see that all these non-invasive positive pressure ventilation strategies involve some type of mask. And these masks vary a little bit in how they lay on the face. Some of them go over the nose, right? A nasal CPAP. Some of them have prongs that go in the nose. Some of them are actually a full face mask, which it looks like these top ones here. Actually, that looks like a full face mask there. So the rationale for all of this is that there's a seal that goes over the face or nose. Then there's this tube here, and this tube hooks up to a machine, and this is the machine that generates the benefit in terms of breathing. So what that looks like and what that means and when to use them. So the first thing to note is that these strategies actually can be used as an inpatient or an outpatient. So some of you watching this at home might be on home CPAP or home BiPAP. There might even be some of you on home AVAPS, although that I think is not as common. And these strategies also can be used within the hospital for patients acutely ill, patients who come in with COPD exacerbations, patients who come in with heart failure exacerbations. We'll get into all that. But they can be used both in the inpatient setting for acute illness as well as the outpatient setting. They also can be used for a variety of different types of respiratory failure, specifically type 1 and type 2 respiratory failure. And what that is kind of just nomenclature we use in the medical field to denote the different types of problems you can have with breathing. So type 1 respiratory failure is low oxygen abbreviated O2, also known as hypoxemia. And that is usually an SpO2 or an oxygen saturation of less than 88%, or a PaO2 of less than 65. This is millimeters of mercury. And for those not in medicine, this is the number that shows up on the monitor, on the vital sign monitor. It's often in blue. And this is from an arterial blood gas. You actually poke the artery, draw blood, and look at the amount of dissolved oxygen in the artery, the PaO2. And that is type 1 respiratory failure. That is in comparison, let's scroll over a little more, to type 2 respiratory failure. Type 2 respiratory failure usually is a problem with ventilation. And what that means is instead of low oxygen, it's actually high carbon dioxide, right? Because when we breathe in oxygen, and then we breathe out, right? And we breathe out carbon dioxide. So low oxygen or high carbon dioxide are both problems that we can get with breathing. And type 1, low oxygen, type 2, high carbon dioxide. And we usually judge this off in arterial blood gas, and we'd say the PCO2 of greater than 45, again, millimeters of mercury, would suggest hypercapnia or high CO2. So this would be hypoxemia, would be another term we would use to describe low oxygen in type 1 respiratory failure. And then hypercapnia, all right, would be a term we use for high CO2 or type 2 respiratory failure. So these non-invasive positive pressure ventilation strategies can be used for both type 1 and type 2 respiratory failure, although in slightly different ways, which we're going to get into as we mentioned. We also, as we kind of already showed you, there's multiple different mask types. The nasal mask, such as we see in this picture here. Then there's the full face mask, the nasal pillow, and we'll go into the different masks and what might make the most sense for who and in what capacity, kind of the pros and cons. And then there's a lot of different settings, a lot of different ways you can set these machines. And we're going to talk about the different etiologies of respiratory failure and how you should set these machines to hopefully help the patient the best, both in the hospital setting and at home. So with no further ado, let's dive in. So what we have written out here is CPAP, BiPAP, and AVAPS. And the first thing we're going to do is we're just going to kind of decipher the full name. So CPAP is continuous. Hopefully I have enough room here. Positive pressure ventilation. BPAP, also known as BiPAP, although BiPAP is technically the brand name, BPAP is kind of the generic name. And this is going to be bilevel. And these names are going to be important because it's going to help you understand what each different type of machine is doing. Bilevel, positive pressure ventilation. All right, and AVAPS, which is going to be average volume assured pressure support. Again, that's kind of a long one, but bear with us, it's going to all start to make sense. So how do these different types of non-invasive positive pressure ventilation work? What is the mechanism of action here? And to really try to grasp that, we have to kind of understand the circuit, how the machine is connected to you, how it's functioning. So if we think about it, and just for the sake of thoroughness, let's pretend this is a mask covering the nose and the mouth. And that mask, as you can see here, is kind of strapped to your face, right? Because it wants a seal. You have to seal the mask around your nose and mouth so that there isn't air leaking out. And then this becomes a closed circuit. You have the machine, right, with tubing that then is connected to this mask that's sealed around your nose and mouth, creating a closed circuit. So what the machine is set to, what pressure it is providing, is what the lungs are going to feel, because you have your nose and mouth, and that goes into your trachea here, which is your windpipe, which then goes into your lungs. And that, again, all becomes a closed circuit. So the pressure that the nose and mouth are feeling from the machine is what the lungs are feeling as well, because there's no air escaping out of the nose or mouth. All that is being transmitted down into the lungs. So then if we talk about mechanism, continuous positive pressure ventilation essentially works by providing a continuous constant pressure. So you set the pressure, and we'll talk about settings down here, but you set a continuous constant pressure that the lungs are always feeling. And what that means, if you think about it, so we're going to I'll erase this in a sec. Actually, maybe I'll draw it lower and we can keep it up so we can reference it again. So essentially, I'll draw a line here. You have your trachea or your windpipe. Then that goes into your main stem bronchi, and that keeps breaking off into these smaller bronchioles, right, on both sides. It's kind of this tree that just keeps branching. And at the end of this tree is what we call a bronchiole with this air-filled sac called an alveolus. And this is where the gas exchange occurs, because the air will flow when you breathe in down your trachea into these smaller bronchioles and eventually into your alveolus. And you have an incredibly large number of these alveolus. They're very small. They're very thin-walled. And the oxygen you breathe in goes into this alveolus, and the alveolus has blood vessels kind of surrounding the outside of it, arteries and veins. And you breathe in, the oxygen comes into the alveolus and it diffuses into the blood vessels. That's how you get oxygen into your body. And then the carbon dioxide that's in, we'll draw it purple just so it's not blue, in kind of the veins, right, surrounding this alveolus, that carbon dioxide diffuses into the alveolus, and then when you expire, when you breathe out, that carbon dioxide leaves the lungs, right? It travels out of the alveolus, and then it goes this way, out of the lungs, through the nose or mouth. So when you have a constant pressure that these lungs are seeing, we've established that, right? There's a seal, it's a closed circuit, and the CPAP machine is providing a constant pressure. Let's say that pressure is 5 millimeters of mercury. What's going to happen then is that pressure is transmitted all the way down to the alveolus, and it can kind of stent the alveoli open, right? Because if you're feeling this 5 millimeters of mercury, that's going to be 5 millimeters that is kind of stenting open, pressing on these small walls and keeping the alveoli open. Because what can happen in different disease states is this alveolus can collapse. You picture it so thin-walled, if you get kind of mucus here, if you have destruction of these small airways from different diseases, that alveolus will collapse down. And when it collapses down, it can't exchange oxygen or carbon dioxide. None of that can diffuse into the body, and none of that can come back out, the oxygen and carbon dioxide. Whereas if this is going on, but then you provide that 5 millimeters of mercury, what you'll see is this will end up being stented open. Even if it has kind of a little gunk, a little obstruction, the 5 millimeters of mercury of pressure will press on these thin walls and stent open the alveolus, so then it can participate in gas exchange, whereas the one that was collapsed down without the continuous pressure cannot participate in gas exchange. So that's how CPAP works. It provides a constant pressure that then stents open those airways, the small airways and alveoli, to provide better gas exchange. And I'm just going to write this in red. So to understand the other BPAP and AVAPS, I'm going to go kind of across the way and talk about the mechanism of BPAP. So CPAP, continuous positive airway pressure, constant pressure. Doesn't matter if you're breathing in or breathing out, that pressure is always there to stent open those airways. BPAP is bilevel positive pressure. So bilevel implying two different levels of positive pressure. One of these is the constant pressure we talked about in CPAP. So BPAP also has that constant pressure that's always there. But in addition to that constant pressure, BPAP says, well, wait a second, I'm also going to provide additional pressure when you breathe in. So it has a constant pressure, and then it also has a second inspiratory pressure. And to make it more understandable, again, we're going to go into settings, but if we put some numbers on this, let's say the constant pressure is 5 millimeters of mercury. That pressure is always there, whether you're breathing in or out. And then the inspiratory pressure might be 12 millimeters of mercury, which means every time you go to take a breath, The BiPAP machine essentially goes, oh, they want to breathe in. I'm going to give them 12 additional millimeters of mercury of pressure to breathe in. And what that does is it allows you to breathe more air in. And you can picture that, right? So you have your 5 millimeters of mercury being provided all the time. Your airways are stented open, right? So you can get gas exchange. But you take a breath in, and let's say you're really tired or you have weakness in your diaphragm, so you can't contract down and take big enough breaths. The BiPAP machine says, that's fine, but I'm going to give you another 12 millimeters of mercury every time you breathe in. And that 12 millimeters of mercury is going to increase the tidal volume. The tidal volume is the cc's, the millimeters of air you breathe in with each breath. Because if you have 12 millimeters of mercury every time you breathe in, if that pressure is being pushed in when you take that breath in, you're going to pull in more tidal volume, more air. All right, so that's the bilevel. You have both the constant pressure that's there all the time, and then every time you take a breath in, the machine gives you additional inspiratory pressure to increase the tidal volume of each breath you're taking, to increase the amount of cc's of air. Let's say you're weak, and with every breath without this pressure, you only take in 200 cc's of air. But then you go on BiPAP, and every time you take a breath, you get 12 more millimeters of mercury of pressure. That might increase this to 500 cc's of air that you're able to take with each breath, right? Because you're getting that pressure-assisted breath. So that's CPAP, continuous positive pressure ventilation, BiPAP, bilevel positive pressure ventilation. So you have a constant pressure and an inspiratory pressure. And then that takes us to the most confusing one, which is AVAPS. And AVAPS is averaged volume assured pressure support. So AVAPS, for all intents and purposes, has both that constant pressure like we talked about, all right, that pressure that is there all the time. It also has an inspiratory pressure, but it gets fancy. And it says, all right, listen, instead of you just setting the inspiratory pressure, right, the amount of pressure you want me to give that patient when they take a breath, instead of doing that, how about you tell me how many cc's of air you want them to breathe? Because we said we are setting the BiPAP, the inspiratory pressure, to increase the amount of tidal volume, right? The cc's of air they're breathing with each breath. That's our goal. But we do it in an indirect way with BiPAP, right? We say, well, let's give them an inspiratory pressure of 12, their expiratory pressure, which is their constant pressure of 5, and then their tidal volume might go from 200 cc's to 400 cc's per breath. And that's nice because we want them to take bigger breaths. AVAPS goes, no, 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 I'm fancy. Instead of setting the inspiratory pressure and the constant pressure, which is the expiratory pressure, I'm going to say, you tell me how many cc's of tidal volume you want them to take with each breath on average, right? And that's the average volume. So I say, okay, fine, AVAPS, I want them to take 400 cc's of air every time they take a breath in. And AVAPS goes, okay, no problem. But I also want you to tell me this inspiratory pressure, how low and how high I can go, right? So then you have a minimum and a maximum. And we'll get into this a little more, but maybe the minimum is 8 and the maximum's 25. And the AVAPS machine goes, no problem. What I'm going to do is I'm going to see how that patient is doing with each breath. And I'm going to give them an inspiratory pressure somewhere between 8 and 25 to average out that each breath they get on average 400 cc's of tidal volume. Average volume assured pressure support. All right. And we'll get into a little more, but that is AVAPS. All right. You're setting a tidal volume you want the patient to get, and then you're setting how low and how high the AVAPS machine can give them an inspiratory pressure to achieve that tidal volume on average each breath. And we're going to break that down a little bit more. So that's the mechanism for each. I wanted to go across the way for that just to hopefully make it maybe easier. I'm going to delete this down here to clear some space up, and we're going to go through indications and settings. I think I maybe want to do settings first because we've sort of kind of already started talking about settings while talking about how each one works. So settings for CPAP, right? We said CPAP is just a continuous positive pressure, right? There's just a single constant pressure. And I kept writing constant pressure. The other verbiage for this is going to be the expiratory pressure, right? Because even when you're expiring, breathing out, that pressure is still there. It's also called the EPAP. You can think of it, for those in medicine, it's kind of like the PEEP, which is the positive end expiratory pressure. All this is the same verbiage. All right, and when you set it, this is what you're setting. You're setting the expiratory pressure, the constant pressure that patient is seeing. And usually it's anywhere from 5 to 30 millimeters of mercury. A lot of people, you'll just start at 5 or 10 of expiratory pressure of EPAP, and then you'll see how that patient is doing. All right, and the other thing on all these machines you set is actually the FiO2, which is the fraction of inspired oxygen. Just out in the world, on room air, the FiO2 is 21%. All right, so that's just normal on room air. And you can decide to set this to everyone. You can have the patient just get 100% oxygen compared to the 21% they get on room air, or you could set it anywhere in between. You could set it at 30, 40, 50, 60, 70, 80, 100%. So you can also set the FiO2. All right, minimum that you would ever set it to would be 21% because that's what the oxygen they'd get on room air. Most people don't go lower than 30 or 40% for kind of no specific reason. So this tends to be anywhere between 30% and 100%. And that is how you set CPAP. So then what are the indications for CPAP? Well, the indications for CPAP are anything that requires that mechanism, kind of stenting open those airways. So what you can think about, a lot of people are on home CPAP for obstructive sleep apnea. Because what happens with obstructive sleep apnea is those soft tissues kind of collapse down and they obstruct the airway leading to sleep apnea. So if CPAP is providing continuous positive pressure, stenting open those airways, it'll stent open that soft tissue so that they won't collapse down and you'll keep breathing. You also can use CPAP for COPD, chronic obstructive pulmonary disease, also known as emphysema. You can use BiPAP as well, but in COPD, you get some destruction and mucus buildup in those small airways, so stenting them open with CPAP can be helpful. You also can use CPAP for things like heart failure, where you get pulmonary edema on the lungs. Because if you picture, right, small airway again, alveolus, pulmonary edema is where you get kind of water on the lungs. And if you get water in the alveoli, they'll kind of collapse down, not exchange gas or anything like that. You put them on CPAP and you give them their 5 millimeters of mercury, a constant pressure, and it's going to stent the airways open and also put that pressure in the alveolus to help the body reabsorb some of that pulmonary edema, and then you can exchange gas better. So you can use it for heart failure as well, and you can use it for anything that's kind of causing a type 1 respiratory failure, which is the hypoxia, and you can use it for some type 2 respiratory failure as well. But these are some of the main ones you'll see it used for. Obstructive sleep apnea, heart failure, COPD. Some people can also use it for obesity, hypoventilation syndrome. The biggest ones you'll use it in the hospital for would be heart failure with pulmonary edema, as well as patients who are kind of on home CPAP for OSA. All right, so let's go over to BiPAP or BPAP. So the settings here, I'm going to start for expiratory pressure just using EPAP for the sake of ease. So on BiPAP, we said it has a constant pressure, just like CPAP does. So that's the EPAP, and the EPAP is just the same as it would be in CPAP. You can set it anywhere from 5 to 30 millimeters of mercury. But then we said BiPAP is bilevel. So it also gives you an inspiratory pressure. Every time you take a breath in, the BiPAP machine gives you additional pressure. And that is going to be known as the IPAP, or the inspiratory pressure, just like the expiratory pressure, which is the constant pressure there, the inspiratory pressure. And this pressure tends to be, you can really set it wherever ever you kind of want it, but it tends to be anywhere from like 10 to 20 as well millimeters of mercury. But the key here, the thing to think about is the delta between the EPAP and the IPAP. So the difference between the two of them, known as the delta, a triangle. And what that means, if we think about it, is let's say you set the EPAP at 5 and then the IPAP at 15. The difference in pressure is 10. So that is actually what they're going to get with their inspiratory pressure, because the EPAP is there all the time. It's continuous. So when then they take a breath in, they inspire and they get an inspiratory pressure of 15. That's really 10 plus the 5 that's already there. So that delta between the two of them is what is important, because that will drive the amount of tidal volume that patient is getting, right? Because we said the inspiratory pressure, the amount of pressure being pushed in when someone takes a breath, drives how many cc's of air they're going to breathe in. And that is how you adjust BiPAP as well. If you have someone who's in a COPD exacerbation, they're hypercapnic, they have type 2 respiratory failure. And we kind of went into indications. One of the big indications for BiPAP, you'll see this in the hospital all of the time, is COPD exacerbations, because they come in and they cannot ventilate. They're hypercapnic. Their CO2 is too high. And the way to get CO2 off the body is to ventilate it off, breathe it off, take bigger breaths. And to help a patient take a bigger breath, you'll put them on BiPAP, right? Because that inspiratory pressure will increase the tidal volume with each breath and help them breathe off that CO2. And let's say you set them at 15/5 and their tidal volume on that is about 500 cc's per breath. But you get another blood gas and they're still hypercapnic, their CO2 is still high. You will actually adjust the IPAP. You might go then to 5/18, because that delta you want to increase. So the delta, instead of 10, is now 13, and that then will lead to an increase in their tidal volumes, right? Because you're pushing more air in, you're giving them a higher inspiratory pressure with each breath. So instead of 500 cc's, it might increase to 600 cc's per breath. And that will then allow that patient to ventilate more and hopefully breathe off more of their CO2. All right, so that's how you would adjust it. The other things we commonly use BiPAP for is you can actually use it for many of the same things as CPAP. So you can use it for heart failure, although you don't necessarily need to. You can use it for obstructive sleep apnea, obesity, hyperventilation syndrome. And then you can also use it for kind of neuromuscular diseases. ALS is a common one you can use it for. Things like Guillain-Barré syndrome, anything where those diaphragm muscles that are what allow us to breathe, right? So if we draw two lungs, here are two lungs, you have your trachea, your windpipe going into your main stem bronchi. Again, that break up in all these smaller things in each lungs. But how you breathe, right? Because you have your lungs are contained in your thorax. And how you actually breathe is you have two diaphragms. These diaphragms are big muscles. They sit at the bottom of the thoracic cage. And when you breathe in, the diaphragms actually contract down. And by contracting down, they make the thoracic cavity negative pressure. And that negative pressure then pulls on the lungs. And it's kind of wild that this is the setup, but this is how it works. Pulls on the lungs, pulls them outward. And when those lungs get pulled outward and expand, it pulls oxygen into the airways. And then when we want to breathe out, the opposite happens. The diaphragms relax, and then they make this thoracic cavity net positive, which pushes the lungs back down to their normal size. And then the CO2 that diffused into the lungs, right, gets pushed back out, and that's how we breathe out the CO2. So anything that weakens these diaphragm are going to not allow a patient to ventilate properly, right? Because their lungs won't be able to expand and contract. whereas the BiPAP will help with that because it provides inspiratory pressure to push open those lungs despite those diaphragm being weak. All right, so a lot of neuromuscular diseases too. And if you think about the inpatient setting, the hospital setting, and I see it all the time when I'm working in the ICU, you can really use BiPAP for almost anything you'd use CPAP for. You could use it for, pulmonary fibrosis, inflammation of the lungs, et cetera, et cetera. So anyone with type 2 or even type 1, which is hypoxia, low oxygen levels, respiratory failure, you can trial BiPAP to see if it will help them. All right, AVAPS, the more confusing one. So what are the settings? So AVAPS, just like BiPAP, just like CPAP, it has an expiratory pressure, an EPAP, which per usual can be anywhere from 5 to 30 millimeters of mercury. Just for the record, 30 is very, very high for EPAP. I think most traditionally you'll see anywhere from 5 to 10. But you certainly could go that high in certain situations, just very uncommon. And then as we said, and I'll scroll over just so you can see my scribble over here. As we said, AVAPS, you actually set a tidal volume. So we've talked a lot about the tidal volume being an indirect result of the pressure settings you put on. AVAPS, though, says, let's just go straight to the source. Set a tidal volume. And you can set it for whatever you want. I think most people do 6 to 8 cc's per kg, so cc's per kilogram. And if someone is 70 kilograms, you can say this is like 420 to 560 cc's of tidal volume per breath. And you actually set that on the machine. But then you also have to set an inspiratory pressure minimum and max. So that's like the IPAP. So we'll just say inspiratory pressure minimum and inspiratory pressure max. And that's what you're allowing the AVAPS machine to use to get to that tidal volume. So, you might say this is anywhere from 10 to, you put, again, whatever you want, 30. That's quite high. Usually the inspiratory pressure minimum you'll set will be 5 to 8 above the EPAP, but the AVAPS then will allow you to, you're allowing the AVAPS to give anywhere from an inspiratory pressure of 10 to an inspiratory pressure of 30 to, on average, achieve the tidal volume you set, which takes into account the patient a little bit more, right? They might not want, that tidal volume on every single breath, or they might want a little bit more on this breath, a little bit less on the next breath. So it kind of helps read each patient and individualize it to that patient rather than just on every breath pushing in the same set standard pressure to try to get them to breathe. So it's a little more comfortable in that sense. And as we said, for both BiPAP and AVAPS, you also set a fraction of inspired oxygen, just like you do for CPAP. And you can set a respiratory rate as well. Usually the respiratory rate is kind of the backup rate, just in case the patient were to stop breathing, because most patients will just breathe on their own. And every time they breathe, it will prompt the AVAPS or the BiPAP to give them that inspiratory pressure. All right. So that is CPAP, BiPAP, and AVAPS. An introduction. There's obviously a lot more complexity here. Oh, I should say AVAPS also you can use for type 1 and type 2 respiratory failure, which is low oxygen. Type 2 is high CO2. But type 2 respiratory failure for AVAPS is really nice because you can guarantee them to get a certain tidal volume. You can guarantee them to ventilate a certain amount. So again, COPD, neuromuscular disease, all the things we kind of talked about over here that have type 2 respiratory failure, AVAPS can be really helpful for. You can also use it for obesity, hypoventilation syndrome, et cetera, et cetera. So that is the introduction. Let's talk about contraindications quick, and then we will wrap things up. So when can you not use these settings? Well, a lot of it is really related to the mask having to go on your face, right? So times you can't use it if you have bad facial trauma or burns, right? If you have big broken maxillary bones or face, you can't strap that mask on and try to push air in and out. Also, if you can't grab the face mask and remove it, it's somewhat of a contraindication because let's say you had the mask on and you throw up. If you can't reach up and pull that mask up after you vomit, the machine's just going to keep pushing air in and out. It's going to push that vomit into your lungs, cause you to aspirate. So typically, we say if you can't grab the mask and remove it, you shouldn't be on this modality, although it's not kind of a firm absolute contraindication. Also, if you're having a lot of vomiting or you can't kind of tolerate your secretions, having a mask pushing air into your lungs is probably not the most helpful thing. Again, aspiration risk. And then they say a relative contraindication too is a recent gastric, which is stomach, or esophageal anastomoses, which is kind of a surgery where they sew or staple things together, because if you are pushing in all that pressure into the lungs, the esophagus runs right by the trachea, and it can sometimes increase the amount of luminal pressure the stomach and esophagus are seeing. All right, so that is the introduction. I was thinking we maybe would make separate videos on each modality and do kind of a deeper dive, as they can be quite complex and, again, very widespread. But let us know what thoughts, comments, questions you have down below. If you're on any of these modalities, we'd love to hear about your experience too, what you're on it for and what have you. So definitely leave us in comments in that regard. We appreciate you all. Check out our other videos, subscribe, hit the bell button, all that jazz. Stay well, keep learning, and we'll see you next time.